In every hospital, some patients have a much higher risk of complications than others. Examples include elderly patients, children, mentally challenged patients, chemotherapy patients, bedridden patients. These patients are at risk of serious complications such as patient falls, pressure ulcers, deep vein thrombosis, DVT, self-harm or suicide. That is why NABH introduced the COP16 standard, which ensures that hospitals identify high-risk patients early and manage them systematically. What you will learn in this video. In this video we will understand what NABH COP16 standard says, what assesses check-in wards and ICUs, common NABH non-conformities, how hospitals can become COP16 compliant. Let's begin. What is NABH COP16 standard? The COP16 standard states, the organization identifies and manages patients who are at high risk of morbidity or mortality. This means hospitals must identify vulnerable patients, provide structured monitoring, implement preventive care measures to ensure patient safety and complication prevention. Objective elements of COP16. COP16 includes several important elements. Identification of vulnerable patients, fall risk assessment and prevention, pressure ulcer risk assessment, deep vein thrombosis, DVT, risk assessment, restraint management. During NABH assessment, these elements are verified through patient records, nursing charts, ward rounds. Vulnerable patients. A vulnerable patient is someone who is at higher risk due to physical condition, mental condition, social or age-related factors, medical condition. These patients require extra monitoring, protection and specialized care. Examples of vulnerable patients: elderly patients, children, differently abled patients, mentally challenged patients. Additional high-risk groups may include patients with suicide risk, comatose patients, critically ill patients. Special clinical groups. Hospitals must also monitor high-risk clinical groups such as patients under sedation or anesthesia, pregnant women, dialysis patients, chemotherapy patients, immunosuppressed patients. Written policy for vulnerable patients. Hospitals must maintain written SOP or policies that define how vulnerable patients are identified, how risks are managed. The policy should also define who is responsible for identifying vulnerable patients, usually doctors, nurses. Monitoring of vulnerable patients. High-risk patients should be closely monitored, typically, at least twice daily. If a patient cannot make medical decisions, then consent should be obtained from family members or legal representatives. Fall risk assessment. Hospitals must identify patients at risk of falls. Fall risk is assessed using validated tools, such as Moss Fall Scale, other validated fall assessment tools. Fall prevention measures. For patients at risk of falls, hospitals should implement preventive measures, such as bed rails, non-slip flooring, patient supervision. These are called universal fall precautions. Pressure ulcer risk assessment. Hospitals must identify patients at risk of pressure ulcers. Risk assessment tools such as Braden scale are commonly used. Pressure ulcer monitoring and prevention. Hospitals must monitor pressure ulcers using staging systems such as APUAP staging, NPUAP staging. Prevention strategies include regular patient repositioning, pressure relief mattresses. Deep vein thrombosis, DVT, risk assessment. Hospitals must identify patients at risk of DVT. Assessment tools such as Wells criteria are commonly used. DVT prevention. Prevention strategies may include early mobilization, anticoagulant therapy, compression devices. These measures reduce the risk of life-threatening blood clots. Restraint management. Hospitals must identify patients who may require restraints for safety. Types of restraints include physical restraints, chemical restraints. However, hospitals must minimize restraint use whenever possible. Restraint authorization. Hospital policies must clearly define who is authorized to apply restraints. When restraints are used, patient monitoring must be more frequent. Possible complications may include neurovascular injury, skin damage. Consent and documentation for restraints. Before applying restraints, family members must be informed about the reason. Medical records must document reason for restraint, duration of restraint. Restraints should also be regularly reassessed for necessity. Common NABH non-conformities in COP16. Common assessment observations include fall risk assessment missing, pressure ulcer documentation incomplete, DVT assessment not performed, vulnerable patient identification missing, restrained documentation incomplete. Hospitals should address these gaps to avoid NABH non-conformities. How hospitals can become COP16 compliant. Hospitals can comply with COP16 by developing SOPs for vulnerable patient identification, implementing fall risk assessment tools, strengthening pressure ulcer prevention protocols, implementing DVT risk assessment systems, establishing restraint monitoring processes. These steps help hospitals effectively comply with NABH COP16 standards. In the next video of this NABH training series, we will discuss COP17, pain management for patients is done in a consistent manner. If you want to learn NABH standards step by step, then like this video, subscribe to the channel, turn on the notification bell, so you never miss upcoming NABH training videos. This is MediQuality Partners, your trusted NABH guide. Thank you for watching.